He probably is. All right. For those of you who have not met Dr. Storch, I'm going to change the PowerPoint in just a moment for him. But Dr. Storch, in addition to being a great friend, together with his wife, Alana, is actually a very well-known doctor. I know that there are some patients here today, I've heard. And I'm going to share very briefly, not about his background, because that's something he can do better than I can. But for me, anytime I hear about a doctor, and I'm sure it's the same for each of you, the greatest referral is not by looking at their bio, but rather happy clients or happy patients. And so for us, as I meet more and more people, or we posted that, oh, Dr. Storch is coming to speak. It's like, oh, he's my doctor. Oh, he's my doctor. I think that's a greater testament than anything I can say here. But again, he has a beautiful family. They've lived here in Arizona for, I think, almost 33 years and practicing since he's moved here. So you have somebody who took all of his studies at NYU, which one was it called? Einstein, thank you. You see, that part I remembered. But I'm going to share the mic with Dr. Storch, and I know that there will be a little bit of a brief time for questions afterwards, but if you have questions that come up that were not able to be addressed here, as long as they're not personal questions in the sense of what should I do, I will forward those questions to him and get answers to you as well. So thank you again. And without any further.
Hello, everybody. I always get nervous when I stand by this thing. Well, if it's February, it's Heart Month. So I'm happy to see you all, and I'm happy to do what I can to support Smile on Seniors. That's not me. That looks more like it.
We'll get you forward on that. No.
This one? Okay. So I know, I always make my audience nervous. Make Levy doubly nervous. Anyway, I was going to talk to you about syncope. Syncope is fainting and loss of consciousness. Obviously, with everybody, especially with our senior groups, yes, we worry a lot about them falling. We worry a lot about them fainting. I'm going to kind of restrict this talk to more about cardiac issues and true out and out syncope, which really implies loss of consciousness. So, so here's your side view of your head. Levy, the key pod goes right here. Okay. And so here's the cerebrum, middle brain, and what's called the brain stem. Right here's your nose, here's your mouth. And so it's the brain stem that keeps us awake. And so if you lose blood flow to the brain stem, you pass out and lose consciousness. So why does this happen to people? Well, there's three reasons. The heart's going too fast, the heart's going too slow, or their blood pressure is too low. But the final common pathway is that you're not getting enough blood flow to that part of your brain. Some people faint. Sometimes it's a little hard to figure this out. Is this really syncope, a true loss of consciousness, or are they intoxicated? Did they have a seizure like epilepsy? Did they have head trauma, concussion? Did they just fall, but they didn't pass out? And that's always a big question because unfortunately a lot of our patients do fall. And my first question is, did you fall or did you faint? Because it's a very different discussion. There are psychiatric conditions where people look like they're having seizures and they're really not when you hook them up to brainwave tests. So these all require evaluation. Syncope is not unusual. You see like a lot of younger, this is sort of the age distribution of ER visits. So yeah, like people around their 20s, sometimes they faint. You know, they faint because they're out exercising, they're having heavy menstrual bleeding, they just faint because they're pregnant. And then people do okay. And as you see, as folks get older, the number of folks showing up in the ER goes up a lot. And it's one of the more common things that we deal with in the emergency room and in the office. And as you can imagine, as folks get older into their 70s and 80s, we're seeing a lot more. So there's all different reasons, and we'll talk about some of these. Orthostatic hypotension means when you stand up, your blood pressure goes down. Abnormal heart rhythms, abnormalities of the heart or lung. 68% are what are called neurally mediated, meaning the heart's actually pumping okay, but there's some problem with the blood pressure or the heart rate control. So, I'm going to step back for a second. I made this slide too big. So here's how the heart works. So here are the upper chambers here, the atria, the right atrium and the left atrium. So a normal impulse that drives the heart starts at what's called the sinoatrial node or the sinus node. So when your doctor says you're in sinus rhythm or your EKG says sinus rhythm, that's a good thing. The impulse is spread out to the upper chambers. That's these lines here. And eventually the impulses make it down to the middle of the heart in something called the atrioventricular node or AV node. And this is the only place in a normal heart where electricity gets from the top of the heart to the bottom of the heart. It's okay, I won't mark it late. And then from there, the impulses spread down through these, what these are called the bundle branches. And some people have a bundle branch block. That means that one of these isn't working. And it's kind of like in your car, you have an electrical system that sends electricity through the wires to the spark plug to make the spark plug go. And in your heart, these electrical impulses travel down these pathways and make the heart contract. And we always, what are those squiggly lines? What are those EKGs? So the first bump here is called a P wave. That's the upper chambers being activated. This big spike we call the QRS. That's the ventricles being activated. There's a lot more muscle in the ventricles compared to the atrium, which is why you get a bigger signal. And then the T wave is the heart kind of recharging itself for the next beat. And again, normal sinus rhythm means your heart's working normally. Lots of times we're concerned that patients have abnormal heart rhythms, and there's a whole slew of different things that we can use to evaluate this. In the old days, we used to use a lot of what are called Holter monitors. Some of you may remember that. You got to put some stickers on you, and then there's these wires that connect to a little recorder on your waist. So now in the what?
I said it was a big recorder, and then it became the.
See, we doctors didn't think they were so big, but we weren't wearing them. So, no, honestly, with the newer modern technology and solid state, so this is what we use instead. It's a little patch here that you just slap on your chest. They can stay on for about a week. You can shower with them. They record everything, and you don't have all the wires and all that. And it's also more discreet. These are other monitors, again, that you can use a similar manner. And they record your heartbeat continuously, but also if you have a symptom, if you have dizziness or you feel your heart pounding or something, you can press the button. And then when we read it out, we say, okay, what did the EKG look like when the patient was feeling such and such? For patients, especially patients with syncope, that's really hard to solve. There's something called a loop recorder, which is what this is. It's actually much smaller. It's about maybe an inch long, and we just put it in under the skin right over your heart. And it's got enough battery to last for about 3 or 4 years. So people are fainting, and especially people who just kind of faint out of nowhere. And these things happen very infrequently. Sometimes that's what we have to resort to see if they're having an abnormal rhythm causing them to faint. That's really the question is, are you having an abnormal heart rhythm making you go down? So, as I said, some people's hearts just go too fast and that makes them faint. Sometimes they have an abnormal rhythm from the upper chambers, something called SVT, in which instead of the sinus node up here driving the electrical activity of the heart, there's another spot in the heart that takes over. It's usually right around here, and it starts going really fast. A lot of our patients, when they have this rhythm called SVT, they'll go at 160, 170, 180. Usually they can tolerate that. Usually once they get above 200, sometimes they'll faint.
Is that blood pressure?
Pulse. Heart rate. This is all heart rate. Some people are born with some abnormal electrical circuits as well that can create some more complicated forms of this. A lot of you may be familiar with something called atrial fibrillation, which is a very common problem that we deal with. Atrial fibrillation very rarely causes fainting. I don't say never, but it's very unusual. A more serious problem is something called ventricular tachycardia. And this means that the lower chambers start racing away on their own. And the heart goes really fast and it doesn't pump very well. This is very dangerous. This is more than just fainting in most people. This is often leads to them passing away unless they are shocked and resuscitated. Usually this happens in patients who have underlying heart problems. meaning they've got a weakened heart, they've got clogged arteries, they've had heart attacks, they have scar in their heart from infection or inflammation. Normal hearts don't usually cause this. Patients who do have this usually get what's called the defibrillator, which is an implantable device that will detect this and immediately shock the heart so that patients stay alive. So the other problem is that sometimes people go too slowly, and this is probably the more common reason why people faint from a cardiac perspective. So here's what I showed you those monitors before. This is what one of the EKG tracings look like. And here's beat, beat, and then the heart just took a little rest and started beating again. Here's another one. This is about 5 seconds long. So now, if your pulse is 60, your heart rate is 60, it means you're beating 1 time per second. There's 1 second between each beat. So in general, a 3-second pause, 3 seconds between beats, especially if you're having symptoms, is enough to warrant a pacemaker. This was obviously done. This was recorded before the patient got their pacemaker. So here's a 5-second pause that we picked up. Again, similar kind of things. Here's also this is in the order about 5 or 6 seconds here. Now, this one actually happened in the middle of the night, and the patient was probably sleeping and may not have been aware of it, because when you're laying down, you can tolerate this. But if you're sitting up or standing up and you have this, you'll start fading out, if not actually completely pass out. Another problem that we see commonly is something called AV block or heart block. And what basically this means is that the impulses from the upper part of the heart don't make it down to the lower part. So your upper part of your heart is going here at about 70, and these big spikes means the lower chamber is probably going at about 30 or so. What? And then you and then you get a pacemaker, and then you're back on the golf course in a few weeks. So
How does blood pressure impact this, or what causes specific blood pressure?
let me go on with my talk, and then I'll get you. If that doesn't answer it, I'll answer it. But this is really a matter of just how rapidly the heart is pumping. If the heart's not pumping fast enough, it's not going to get enough blood upstairs. Just skip ahead here. So many people are familiar with pacemakers. So pacemaker is a device that prevents your heart from going too slowly. And the old-fashioned way or the standard way is that there's a unit that's implanted in your upper chest. We insert wires that go into the vein underneath your collarbone and pass those wires down through your veins into the heart. Here's one in the right atrium, here's one in the right ventricle. And if, for some people, so let's say where they have complete heart block and the impulses from the upper chambers don't get to the lower chambers, then basically this is a new electrical bridge between the top and bottom of the heart. If the upper chambers aren't going fast enough, the pacemaker makes it go fast enough. So let's say we set your pacemaker at 60. If your heart's going faster than 60, the pacemaker is just standing and watching, like leaving the corner. And if if the heart's going too slowly, then the pacemaker will make sure that your heart stays at that lower rate. There's some new generations of pacemakers that are really exciting. They're not appropriate for every patient, but they're appropriate for many. And these are what are called leadless pacemakers. And so this is the whole pacemaker right here. You should pardon the comparison. It's like putting a bullet in the heart. And it doesn't have all these wires and all this. And so you don't have all the potential complications associated with that. And the whole battery, computer, electrodes are all contained in there. So there's some interesting technology that's on the forefront. And then just to point out, when we evaluate patients, it's not just what their heart rhythm is, but what else is going on in their heart. Do they have a heart murmur problem? Do they have a heart valve problem? There's other studies that we can do when patients are fainting. There's something called a tilt table where we hook them up to all kinds of monitors and stand them up and see what happens. So the EP or electrophysiologists are heart specialists who deal with all sorts of electrical problems. They put in our pacemakers and defibrillators for us. But again, I mean, fainting is such a common problem that every cardiologist deals with it. But a lot of those issues also mean, between echocardiogram, CT, MRI, these are all ways of evaluating what the structure of the heart is. And a lot of these evaluations and decisions all play into whether the heart is structurally normal, whether the heart's weakened, whether there's a heart valve problem. So I'm going to go on and talk about blood pressure a little bit. Remember I said if your blood pressure is too low, you're not getting enough blood to that part of the brain, and that's going to cause you to faint.
What's low and what's normal range for people older?
So the question is, what's a normal blood pressure? And the answer is it kind of varies. I mean, there are lots of younger, healthy, skinny people running around Scottsdale whose top number is like in the 80s or low 90s, and they're totally fine. As people get older and as we get older, our arteries get a little stiffer, and so your system has to operate at a higher pressure. So for most people, we're sort of aiming to keep them in like the 120, 130 range. Above 140 over 90 is considered hypertension. Okay. So everybody's different and everybody's systems work but if your blood pressure is too low to keep you steady, to prevent you from falling, then that's a problem. And sometimes it's because of dehydration or anemia. In other words, your heart's pumping fine, but it doesn't have enough blood to pump on. Certainly medications are a very big issue for us. Heart valve disorders, for example, aortic stenosis is a narrowing of the aortic valve. That's the main valve that all the blood passes through as it leaves your heart. Hypertrophic cardiomyopathy is an inherited disorder where the heart muscle is too thick, and this can also cause people to pass out. A lot of times, like when you see young athletes pass out or drop dead on the practice field, a lot of them have this, unfortunately. The pulmonary embolism means a blood clot gets into the lungs, usually from the veins in your leg. And if it's large enough, it can obstruct blood flow enough to drop your blood pressure and make you pass out. Pericardial effusion is fluid in the sac around the heart that compresses the heart and prevents blood from getting back into the heart, so your heart doesn't have enough blood to pump on. And then we're going to talk about some of this stuff with the vagal nerve and autonomic dysfunction as we go along. But these have to do with how your nervous system regulates your blood pressure. So there's something called orthostatic hypotension, which is in plain English means when you stand up, your blood pressure goes down. And this is a very common thing. I mean, everybody's had it, right? You're laying on the couch, somebody knocks on the door, you jump up and like, oh my God, you're woozy, right? Because you're jumping up faster than your heart, and your blood vessels can react to the change in posture, change in position. And we identify this as when you go from standing to or laying down to standing, your blood pressure drops by 20 points or more, or you drop to below 90, or the diastolic drops by more than 10 with dizziness associated with it. So it's not unusual, and especially, about 20% of the people who live out, in their own homes will have it. About half of people who live in some sort of facility or institution. Why? Because they're very, they have limited mobility. They don't drink enough fluid. Maybe they're on a sodium restricted diet on top of it. But, if you're not able to get up and walk around a lot, you're not going to go to the fridge and, grab a bottle of water anytime you want. Add to that, we live in one of the hottest places in the world, okay, which is a very big problem. It's a very big challenge, and a lot of our patients take different medicines in the winter compared with the summer because everybody's dehydrated in the summer, and everybody's wilting, and everybody's blood pressure is down. And I'm telling you, about early June, we start getting the phone calls in the office. I don't feel well, I'm tired, I'm weak, I'm over-medicated. And you know what? By the time the holidays come around September, we don't get those calls anymore when the weather breaks. So medications can cause this orthostatic hypotension, especially water pills. Vasodilators or nitrates, things like isosorbide, nitroglycerin that you put under your tongue. These hydralazine is a blood pressure medicine. Alpha blockers are very common. They're blood pressure medicines, and also just about every older male is taking these for his prostate, things like Flomax or tamsulosin. Calcium channel blockers. Beta blockers and calcium blockers are very commonly used medications in the cardiology world. Sedatives, benzodiazepines are things like Valium and lorazepam, Ativan, etc. And then some meds for Parkinson's will cause this. And then also antidepressants, tricyclics like Amitriptyline will also be a problem. Phenothiazines, we don't use as much. So sometimes this is something that you can correct. If people are vomiting or they're having losing a lot of fluids with diarrhea, if they're bleeding a lot, you know, some younger women, if they have heavy cycles, people are not eating enough. High blood sugar will contribute to this. And the reason is that when you have high blood sugar, if you're diabetic, once your blood sugar hits about 180 or so, the sugar itself starts acting like a water pill and making you pee more. And a variety of, and again, the medications will contribute to this. Now, sometimes people have enough fluid in their system, and the problem is more that the body doesn't regulate the blood pressure properly. And we see this in some of our folks with Parkinson's disease, Lewy body dementia, and some other neurologic syndromes that older people unfortunately suffer with. And despite giving them a lot of fluid and making sure that there's enough fluid in their system, they still will have problems with fainting or falling because their blood pressure their blood pressure drops when they stand up. Diabetes can contribute to this because diabetes affects the nerves that control your blood pressure. Alcoholism never helps anything. Chemotherapy sometimes will affect the nerves, and a lot of people unfortunately have neuropathy when they go through chemo, HIV, AIDS, and some other sort of weird stuff that we don't see very often. So when people have orthostatic hypotension, we want them to take in a lot of salt and fluid. Yeah, it's kind of weird. It's, you know, believe it or not, there are some patients where I have to tell them, drink more fluid and eat more salt. Okay, there is, you know, as Bernie Sanders says, they're the 1%ers, but they exist. And there are some people that really need to drink a lot of fluid and eat a lot of salt, otherwise they're dizzy and they're going to fall. Compression stockings help as well. The higher the better. Some people wear thigh-high ones, some people calf, sometimes even up to their belly. And what that does is just compresses the veins. So when you stand up, there's less space in the veins for the blood to fill up. So the blood is kind of pushed up and gets back to your heart. The problem with the blood pressure dropping is that when you stand up, the blood sinks to your feet, and then your heart doesn't have enough blood to pump. Counterpressure measures are like tensing up your muscles in certain ways to raise your blood pressure. And then, of course, any medications that we can get rid of, we're happy to do so. There are some medications that will treat orthostatic hypotension. There's something called fludrocortisone, which is a normally occurring adrenal hormone in your body. It's a water retention pill as opposed to a diuretic. Midodrine is something that we use very commonly. Droxidopa has come on the market a few years ago. It's still brand name, so it's expensive. We don't use a lot of it. Oops. And last but not least, I just want to talk about something with the vagus nerve and what's called vasovagal syndromes, because this happens to a lot of people. So the vagus nerve is one of the involuntary nerves in your body. When I say involuntary nerves, there are some nerves that control things, right? So you can make your arm straight and you can make your arm contract. That's all under your brain's control. But there's a lot of stuff happening in your body that you're not controlling. Okay, you all had a delicious lunch, I hope, and your esophagus and your stomach and your intestines are all contracting and moving the food through as it's being digested. And nobody here is thinking, nobody's brain is telling their gut, do this, okay? So there's a lot, and the body has a lot of different mechanisms to regulate all sorts of functions, including heart rate and blood pressure. So the vagus nerve, we were told in medical school, vagus means wanderer, like vagabond, and it has nothing to do with Las Vegas. And it wanders through your body. It starts in the brainstem and it goes to just about everything. It goes to some branches in your neck. It goes to your heart. It goes to your GI tract until you're about 2/3 of the way down your intestine. It's connected to your skin. It's connected to your blood vessels. When the vagus nerve gets activated, it can slow your heart down, and it can also relax your blood vessels, which lowers your blood pressure. And in the right setting, this can make people faint. So this is like the classic things that you see when people faint at the sight of blood or something gory, when they're scared. You know, people who are afraid of needles, or they shouldn't say afraid of needles, they just don't do well with them. I know doctors who are like this, okay? There's one doctor who I regard as one of the best doctors I've ever worked with. He and I went to give blood one day. They just started asking him questions. And, you know, 15 minutes later, we were both laying on the couch. I was giving blood. He was just recovering from the questions. I'm talking. It's my wife. I mean, also when people have pain, this will often trigger, right? So, you know, like if you're hammering a nail and you hit your finger instead, and you feel like a little queasy in the pit of your stomach, you get a little clammy, a little sweaty. This is all the vagus nerve activating. So everybody, I'm sure, has experienced it, but sometimes it comes on just for no good reason. Sometimes emotional stress, being in a hot, crowded place, and people faint. I've seen it both after meals and before meals, and one of the most common situations is you folks go out to dinner, and somebody starts feeling a little faint at the table, maybe getting a little clammy, a little sweaty, and then they said, you know what? I'm going to go outside and get some fresh air. And as soon as they stand up, wham, down they go. Then they call the EMS and they schlep them to the hospital, and that's the end of dinner. Okay. So the treatment is, if you start feeling that way, put your head on the table, put your head on your neighbor's lap. Don't stand up. This usually passes in about 10 or 15 minutes. Okay. If you're in a position where you can lay down and put your legs up, you'll make it go a little bit faster. But again, there's nothing really to do for this. There's no treatment for this. It's just a matter of understanding the early signs and protecting yourself so that you don't fall and hurt yourself. Because falls, you know, people injure themselves when they fall. They hit their head, they break their hip. Everybody here knows somebody that fell and broke their hip. So, yeah, so the key is kind of recognizing the setting of feeling clammy and a little sweaty and turning a little pale, and just recognizing those signs and getting yourself to a safe position so you don't fall and hurt yourself. And I think with that, as always, you gave me an embarrassing introduction. Well, I'm going to give you an embarrassing conclusion. Thank Connie and Levy for all they do. And we're privileged to see not only the face-to-face stuff that they do, but we get to see some of the behind-the-scenes stuff as well. Yeah. You got 5 minutes.
Okay. So
I would have had 15 minutes, but there's all the traffic from the open.
Yes. All right.
My sister was diagnosed with an LPA elevation, and she said that I should be tested for LPA to eliminate
I'll repeat the question. It's a little off topic, but I'll give you the 10-second answer. Lipoprotein A, or LPA, is another kind of bad cholesterol that does not show up on the standard cholesterol profiles that we do. It is patients who have higher levels or at higher risk of heart attacks, clogged arteries, and also narrowing of the aortic valve. It's genetically inherited. And unfortunately, it doesn't come down with cholesterol medicines like statins, although there are some drugs in the pipeline for it. So if there is a family member who has it, other family members should be screened, because it gives us an additional data point in understanding their risk of having a heart attack.
So I should do it. I should get that. Is there medicine for it? And does it help?
The questions are the medicines for it. The answer is there are medicines in the pipeline that lower lipoprotein A, and there are trials ongoing, including Honor Health has some, then I have some patients in this. And now we're trying to understand if you lower the level, does that decrease the risk of bad things happening to people?
All right. I'm going with
Well,
I know that blood flow, you mentioned about blood flow different along different parts of the body, but it doesn't mean you don't play a big part
in any particular area that it would go, or is it just something that is a factor in something like that might happen?
So fainting is usually caused more by severe anemia, like when patients are bleeding. Okay, that, you know, internal bleeding in their stomach or from their colon or such, you know, because when that happens, you know, all of a sudden you decrease the amount of blood volume in the bloodstream. Okay, so even if the heart is pumping well, it has to have enough blood to pump on. Anemia that develops more chronically is usually not a problem because your body will have enough fluid in your system. I mean, it's not a good thing to have anemia, I agree with you, but it's usually the sudden anemia, sudden bleeding that's going to make people faint. Okay.
I hear a lot of anecdotal comments about people using their smart watches to be very effective in diagnostics. And do you recommend them? I mean, they say that they can use for hard situations.
So the question is about smartwatches like Apple Watches, and there's also a device called Cardiomobile. It's the only thing I ever see advertised on TV that I might tell my patients to get. It's this little electrode panel that you get, and you need an app that goes with your phone. So these are very helpful for a couple of reasons. Things like the Apple Watch actually will sometimes pick up atrial fibrillation and other irregular heart rhythms, and patients see we didn't even know that they had it. And then these devices enable you to do an EKG if you're not feeling well. So if you're feeling dizzy or lightheaded, or you're feeling your heart racing or palpitations, they're helpful for those kind of diagnoses to see what the heart rhythm is doing at that time. You know, I showed you some of the devices that we put on patients, but those are anywhere from a few days to maybe a month. You know, so this way, you know, with the Cardiomobile or an Apple Watch, I don't tell people I spend their money, but Cardiomobile $79, $5 off because it's Heart Month, and Apple Watches are a few $100s. But they both enable you to actually do an EKG while you're not feeling well. So that's helpful. Now, as far as fainting, they're not helpful. Okay, because right, you have to be able to activate the device and make a recording. Okay, so it's helpful for evaluating people with palpitations and concern for regular heart rhythms. It's not helpful for our fainting patients.
That's funny because that was part of my question. I just got a Cardiomobile delivered to our house yesterday.
Okay.
I was diagnosed a while ago with paroxysmal atrial tachycardia, and there's no rhyme or reason when it happens. And when it does happen, it could last for hours. So my doctor had given me metropolol, but I was afraid to take it. I thought it would lower my heart, you know, too much. If I'm already on my 5 milligram of amlodipine, when I get this tachycardia thing, can I also take the metropolol?
Speaking in general terms, amlodipine only lowers the blood pressure and has no effect on your heartbeat. Metoprolol is a beta blocker that slows the heartbeat and lowers your blood pressure. And the rest of the answers need to come from your doctor.
Yeah.